us know more about the aspect of interpretation of thyroid function tests in day-to-day practice. The speaker for this important topic is Dr. ALTAMASH Sheikh. Dr. ALTAMASH Sheikh is a consultant endocrinologist at a host of hospitals in Mumbai. He is the joint treasurer of Maharashtra Endocrine Society. He has a number of awards to his credit and is also a speaker for various national and international conferences. The chairpersons for this talk are Senior Physician Dr. Bhushan Mapari and Professor and Head, Department of Medicine, GMC Akola, Dr. Mukund Ashtaputre. I humbly request them to kindly occupy their chairs.
Gave me a headed yes, nodding head. Thank you. How is the tea? Everybody has had tea over there. I think just taking from the last question, this becomes medical because this is a place where you have an endocrinologist. The patient was pregnant till the last trimester. She was on anti-thyroid drug and the baby's TSH is there. So what was the trap of this particular lady when she was pregnant? Number two, was a fetal goiter test done or not? So these two are, I think, very important things. This patient should have been taken one opinion of an endocrinologist, and the patient may have kept with you only as a physician if you were there in a particular place where there was no endocrinologist. Coming back to this particular thing, day to day, I'm going to show you some absolutely pictures, and I request Dr. Sunita Madam to please delete this presentation once this is done. What do we see in day-to-day practice? This is exactly what has happened with our journey from yesterday when all of us left Mumbai till today. It's a little tricky situation, but however, first thing what you need to do when you look at a TF is that look at the clinical symptom. Why are you going to think, or why do you think that the patient was sent the thyroid function test? What are you suspicious about? What are you thinking? What abnormality could come in this particular patient with this particular symptom? And three, what has happened with T3 and T4, that result that you are going to expect? And is there an appropriate TSH feedback? I think Dr. Jayawant and Dr. Yerav also talked about PTH and calcium relationship. Similarly, those relationship of the hormone, the feedbacks have to be seen in a complete way. And then you come out to a diagnosis that what to be done. So here showing you case 1. This is approximately a patient of 61 years age, obese, type 2 diabetes for 5 years, develops inferior wall MI, TSH is 0.2 and FT4 is 0.3. Anybody? CQ thyroid straight away. Okay, one possibility. Let's go little stepwise. First I said look at the symptom. Does the patient have any symptom which may correlate with the thyroid at the moment? No. But T3, T4 is being sent. So what are we going to expect? Was it even needed to send T3, T4 TSH for this particular patient? No. Maybe no. Pre-test. Super. Whoever said that. And 0.3 was T3 and T4. How much is the T4 here? It is a little on the low side. And is the TSH feedback appropriately normal, low or high for that T4? Possibilities are there. So this is one case, see, day to day, which really intrigues us, and I'm going to show you some more important things that avoid testing in such cases unless it is strongly suspected to have, especially you may get this kind of illnesses. Now, this is a spectrum of sickle thyroid syndrome. Let me ask you a question by showing you this next photo. How do you interpret this particular image? Dr. Govind will laugh at me when I show this. See, he's laughing. What do you see here? Somebody is aspiring to attend Dr. Anita's program because she's involved IMA and API and Maharashtra Endocrine Society. This guy is trying to see that at 5 p.m. I'm going to become thin suddenly because I'm going to listen to a lot of endocrinologists and I'll be able to wear Manivata, whatever that next thing is. If you do T3, T4, TSH in this kind of a patient on a day-to-day circle, what will happen? You will get normal result. So avoid doing tests when it is not required. Nowadays I understand patients do come with a battery of tests, 100 rupees and 800 tests, suddenly those packages are also there. But be very careful, be watchful, be vigilant about what we need to do. I really want to meet this person, whoever is this. Will he be there today in the program? I've been told there will be 250 people waiting at the IMA at 5 p.m. Okay. Next question. All the factors influence serum TSH in hypothyroidism except? Is it race? Anybody? How many for race? Is it age? Is it obesity? How many for obesity? How many for euthermia? Okay, a lot of endocrinologists are there. I'm impressed with their knowledge since morning. You're right, actually, it's euthermia. We were told that you all have to please get your thermal clothes, you get this, get sweater and whatnot. So I thought let me put that TSH and temperature related thing. Euthermia here will not have an impact, and that's how we all were comfortable yesterday in the train without wearing any overcoat or without having anything. We didn't even, some of us didn't even need any even bedsheet also. We were just sleeping like that. And endocrinologists do enjoy. See the, look at the box that you all are eating. It's a lavish dinner, thanks to Madhur, who really took care of all of us. But why am I showing you this? Because there is something in this food which can affect the absorption of P4. I'm going to show you in forthcoming cases. Hanuman Chedewal. Now you all are expert, you know how to interpret this TFT. Anybody? What is the diagnosis here? That's the loop of feedback that we look at from DRH to TSH to 3T4, and that's how the whole cycle goes on. These are the tests which are usually available, and think before writing why you want a particular test. PrEP is available with almost everywhere in India at the moment. Even with the bigger lab collection facilities, you could have this. The pre-lab, lab and post-lab important distinction is to be done. A few things are to be kept in mind about how we move about, whether it's age, I think the previous speaker talked about age and pregnancy, thyroxine therapy, confounding medication, whether you would look at heterophile antibodies. I have slides for each of the cases, but I think I'll wait for the bell whenever they want. I'll just finish it up quickly. And even post-lab, whether it's resistant to thyroid hormone, whether it is problem at the level of transport, or whether it is a tumor of TSH that we call as stroma. So although they are rare tumors, but we do see. This is what would be, you'll be thinking majorly. Now I know a lot of you will argue that, but we get patients with TFT. This is what is one red circle that we need to think about most of the times. Thyroiditis may be confusing a lot of times depending upon at which stage, at what severity the TFTs were done for that particular patient. A lot of things, luckily we didn't have a dietary soya yesterday when we had our food. None of us were on metformin when we had that particular box. And if you see there can be a change in TSH with diurnal rhythm or sometimes circadian rhythm or variations also. However, remember, we see a lot of prescriptions even today. Thyroxine is given in the morning, calcium is given in the morning, and also an iron supplement is there in the morning after breakfast. That should be at least a 4 to 5 hours of gap when we are writing that kind of a particular prescription to patients. Now, this is one diagram, one line, one flow chart to talk about how you take care of important. I told about calcium and iron, but if you look at sucralfate over there, look at orlistat. A lot of people to suddenly reduce weight, they are put up on orlistat morning and evening, and it does have interference in absorption of thyroid hormones, and we should be very careful about using orlistat in the morning with these particular patients. Now, some conditions where you should not be using only TSH, where it can be misleading. These are those anomalous conditions where you should be careful, whether it's a central hypothyroidism, NTIs, as you all saw the previous case, resistance or Sjogren's. Interpretation, this is a very important slide again. The only message is that look at the symptom, suspicion, serum levels, appropriate TSH levels, and look at your diagnosis. Let's look at this case. It's a young girl, 30 years old, married lady, complains of fatigue, dizziness, nervousness, anxiety, occasional palpitations, and weight loss since 4 to 8 weeks. No family history of thyrotoxicosis, but there is a family history of thyroid disease, hypothyroidism in mother. There is no discomfort in the neck or dysphagia, no shortness of breath, nothing that would suggest any other abnormality about thyroid case. Her TSH is 1, read this as 1.0, T3 is normal and T4 is also normal. What is the diagnosis? 30-year lady, these are the symptoms 4 to 8 weeks. This is the TFT. Clinical hypothyroidism. Sir, TSH is 1. Hyper. TSH is 1, I'm saying. Okay, my chairperson is answering from here. Let's take from the audience first. Okay, anybody? Any other answer? Your thought was right, but TSH is 1. This is a normal report. Please understand that you will get patients, even though they are symptomatic, the pre-test probability is right over here for whatever reason. T3, T4 is normal and appropriate feedback. As I said, TSH is 1. That is also normal. Please leave it, and my chairperson is absolutely right. You need to just observe this patient. This patient at the moment does not have any kind of an anomalous TFT. That's supposing, I think one of them said subclinical hyperthyroidism. Supposing actually अगर इसका TSH 0.1 ही है, then what is the diagnosis? Then what you said is right. Maybe subclinical hyperthyroidism or anything else. No, then it's not normal because 0.1 है. Let's look at the history again. Clinical symptom. 30 years. She's got dizziness, palpitation, weight loss, 4 to 8 weeks, whatever. And now the TSH is actually 0.1. Pregnancy. I think he was shouting his thumbs out about it. This could be pregnancy in that case. Actually, because I said that's a married lady, and this is how if you, somebody is from Akola in this photo. It's from Minor, I think. Yeah. Right. So 50 years lady, hair growth, wants very good hair, right dimple paparia, but got a patch instead, the other way. She did not do her stuff properly. FT4 is high, FT3 is high, TSH is very low. What is the diagnosis here? Somebody saying, yeah, go ahead, little louder. Graves is possible, so there is some kind of thyrotoxicosis. Symptom point of view, hair loss is there, which may be present, not present, we could have eaten history. But there is a desire. So was the pre-test thing right? Yeah. You want to grow hair, thyroid has a component. 4 important hormones that have this thing in growth, metabolism of hair growth, thyroid, cortisol, growth hormone, and these are important. So this is required. Now, this patient, what happened is, I was talking about pre-test and post-test probabilities. That's where that slide comes into picture. This patient was taking some vitamin already for increasing hair growth. And that drug is responsible for this kind of an abnormal TFT. So again, that particular problem was because of bioaccumulated reagent antibodies which were present in the analyte bound, and what we need to do is we need to stop that particular hair vitamin which she was taking, because biotin is requirement is very, very small. The recommendation is stop that particular biotin vitamin tablet for 3 to 7 days, repeat it, and it will become absolutely normal. I think 2015, end of 2016 January, we got first time that we were biotin, and that's how I think we have to be very, very careful. Whoever comes with skin and hair issue, that their TFTs need to be repeated, and if the patient has got that particular vitamin, please remove, stop it, halt it for 3 to 7 days, then repeat it. These are the usual patterns that you would see. Let's take 6th case. 26 years lady with Hashimoto's disease, TSH, there's a wide fluctuation between 76 to 276. Multiple escalations of a thyroid hormone dosage led to hospitalization for tachycardia, which is a usual thing. TSH is uncontrolled. Anybody in the world is going to change the dose, and FT4 was used for subsequent dose adjustment, and her levothyroxine dose was reduced to a weight-based dose because she got tachycardia. What was the issue here? Her blood. Here she was not on any tablet or any vitamin. Here she had a Hama antibodies which are present. So the test needs to be done, or the heterophilic antibody interference needs to be ruled out in such cases. That's how you approach in these cases. Next, 44 years, Bollywood actor, routine visit to endocrinologist. Normally, you thyroid on 100 once a day. Very good compliance. So very educated, very talented, very regular, very healthy. Gets up at 4 a.m. Don't guess who is he. TSH is 99. And look at the FT4. How much is it? 1.7. Kind of little low. Clinical profile not matching with the lab test. Absolutely. Something is amiss. Anybody can think, what is this? Guess the PhD diagnosis, not the name of the actor, please. Yes, go ahead. So what are those? You're right.
He's keeping tablet and taking the tablet on the day of the test.
He's keeping the tablet in the house and taking the tablet only on the day of test. Well thought, you may be right. This may be one of the right options, actually. Anything else? Any other thought that comes to your mind?
So he might be working late in the nights, consuming something.
Absorption issues, very good, yeah. So he's having very late night, but I said he gets up at 4 a.m. So there's the issue that he's not keeping that gap of 30 minutes, but he was doing it. His dinner is around 7:30 p.m. at night. He takes the tablet sharp at 4 a.m. in the morning. So taking the tablet, keeping the gap is normal. He's doing that 30 minutes, waiting, all that thing, absolutely everything is right. And he's quite talented, educated, he knows everything. Still something was amiss. And he doesn't have those antibodies which I showed in the previous case. That was also ruled out. And he was not on any vitamins. He used to work like CID sometimes. I told him, you bring your bottle and show. And this is what he showed. His tablet was given by his assistant, and he had removed the cotton, he had removed the silica gel inside which is there in the bottle. So the tablets are hygroscopic, the tablets had melted. Therefore, what he was eating was only tuna, and not the tablet. Thyroxine was not doing. So what you thought was right. Yeah, there was a confusion actually. The tablet wasn't going in his tummy. Okay. Let me know if my time is up. Interpretation, as I said, look at the symptom, treat a suspicion, look at the serum levels, and look at what is the dose or what you will do. What is the diagnosis here? Anybody? Acromegaly. Okay, 2 people say acromegaly. Any other diagnosis? This was his MRI, showing a large pituitary tumor. He was subjected for pituitary surgery, and then Dr. Anita was called. What will she do with this particular patient? Will you allow this to operate, or will she not allow this patient to operate? He looks clearly acromegaly, full marks to everybody, but this is the MRI. The problem was in the lab which was doing TSH. The TSH was repeated, TSH was shown to be very high. In subsequent examinations, this patient had actually a pseudo-acromegaly. Full marks once again to you. So this was one of the first cases presented from India. Primary hypothyroidism presenting a pseudoacromegaly. You won't believe his photo when I show you in the next slide after treatment. This was his actually face. So it was TSH acting as severe insulin resistance. It was like acting more over prolactin receptors, which sometimes we call as a fugitive acromegaly. Here it was a pseudoacromegaly. Look at the TFT. Maybe we'll take this as a last case. I don't know if the time is over. 44 years male, on treatment, thyroxine 100 microgram per day, TSH is 1, T4 is low, because the values in T4 is low, T3 is just good. And he was eating this. What is this? Except Ramay, everybody can answer. Ramay knows where I have taken this book. Any guesses? Chikmagalur. Visit to South India. He had this. These are coffee beans. Coffee, espresso coffee specialty is known to alter thyroid function test. There is some new data about tea also, but do not tell it to your patients. Best is 30 minutes minimum, wait for your tea, coffee or breakfast and then take it from there. Coffee does interfere. And I am really impressed with Anita Madam's hospitality. Today morning, 5:30, she called us to her house and she gave us tea and whatnot. At least 45 things were there. I almost felt like a son-in-law in your house. That she's standing and serving us tea. Thank you so much. Amay was also there. Amay, you are just there. I think his father-in-law came in between. So, endocrine in day-to-day practice. One more slide. Right. About food, we usually get a question. There is no food which you take it and your thyroid goes away. And there is no food that you would avoid and your thyroid will come back. Be very clear with patients what we are talking. Be very clear about the data that is coming. You can have soya, you can have cabbage, you can have cauliflower, you can have broccoli, you can have bok choy, you can have collard green, provided they are cooked once in a week to once in 10 days. There is no problem at all. There was some problem, some data earlier, 30-40 years back, talking about this. When you have these things in raw state, it can cause issues with TFDs, but not otherwise. Is my time not over yet?
We have 5 more minutes.
5 minutes.
Yes.
She's very kind to all of you. Not a potential symptom or sign of thyroid cancer. Persistent cough, raw throat not relieved by routine treatment, difficulty in swallowing without goiter seen in neck, or is it hoarseness or voice change that goes away with routine treatment, which is not a sign of thyroid cancer. Very common question, very routine thing. They have come with some swelling. She's been told that this is my sasubai to mala thyroid cancer. What is not a potential sign or symptom? Yes, sir. Be loud, whoever is answering. Raw throat, right? Whoever said that. It's the raw throat not relieved by routine treatment that needs to be considered very, very importantly. A lot of abnormal TFD were there in this particular patient. I think this slide should be there. It's not there. Yeah, but this is the TFD came normal. This was the slide. Yeah. It's a female patient. TFD came normal. And this was her neck. Now what was the diagnosis? Try to connect all the lectures from morning. It's not testes, please. It's a female patient. This is neck. This is a multinodular goiter. Please, Anuraga and Madhura not here. This is not puberty. This is thyroid. This is multinodular goiter. I said that TFTs were normal. Right. Let us become owner to our own health and not become owner to our disease. And I think with that, I would like to take questions with the permission of organizers and Sheikh. Thank you so much, ladies and gentlemen.
Thank you, Dr. Altamash. It was educating and guiding also. The session is open for questions, if any.
Sir, if heterophile antibodies are positive, then what next? How should we go further treating this patient? Because the TSH will remain on higher side in that case.
So, resistance to thyroid hormone and heterophile antibodies. What we have seen in cases is you give higher dose, keep T4 in a normal range, and they do well. And if it is only resistance to thyroid hormone, then you don't need to treat those with thyroxine. Nephrologist is asking a question. You're only holding a mic. Okay.
Yeah.
Please.
Sir, does vaccination affect thyroid, especially in young kids as well as in adults? And how does it?
It may. There can be a subclinical thyroiditis. It has been seen with even the latest available vaccine. I don't need to name that vaccine. So it is very much seen. There have been published literature even from India.
Any questions? So may I ask one question, please?
Yes.
So with all the era of adequate protein intake, more and more vegetarians do not want protein supplementation and go on for soya every single day as high as 100 grams per day. In your practice, have you seen such bodybuilding patients coming up with hypothyroidism due to soya consumption, cooked soya consumption?
Not only because of soya, but there can be other reasons. And it's not just 100 grams. Some of the bodybuilders we see, they have taken, even though they weigh 110 kg, I have seen them having as high as 300 grams of protein a day, including from veg and all other sources. But even vegetarian people do have that much high. They take either whey or they take some other form of protein. So that is more because If your kidney is damaged, your creatinine is high, there is a leakage at the level of membrane of renals, there is a loss of T4, that may trigger in that way, there will be a nephrotic-like picture. We do not know the mechanisms exactly, but these are possible.
But due to soya per se,
No,
onset
only
of
soya will not cause, and if you've given the treatment, even supposing for somebody who's a known hypothyroid, if you've given that 30 minutes away, it will not cause any interference also in the ASS.
Thank you so much, sir.
Thank you.
To come forward and felicitate the chairperson.